Hello and welcome. This is your Brain on Drugs Psychiatry podcast. Punk rock psychiatrist here, and today we're going to be talking about tricyclic antidepressants. So we're getting through. We did the MAOIs on the last one, and today we are going to go over tricyclics. And these are another older class of antidepressants, and we'll go into the more modern ones after we get through this in this lecture. So I'm still trying to get the screen sharing working. The editing software is put in a trouble ticket trying to figure that out, but you still can find the slides on the website. So to start off this lecture, I actually wanted to start off with neuroreceptors first, because the tricyclics are so complicated in how they interact. And this is a concept that is really what got me into learning about the or the psychiatric medications in the first place. Was how do all these different psychiatric medications interact with all these different receptors? And so I made this big spreadsheet to try and explain it. And so I'm going to go over that, and we're going to go through all these different receptors that are in the brain. And then we'll talk about the tricyclics and how they differ from each other and how they interact with some of these receptors. So if you can see it, following along, I started off with the histamine 1 receptor. And so this is, of course, what's used for allergies, right? The antihistamines. And so on the left, I've got the site of action, the receptor's name. And on the right side, I've got consequences of a blockade. So this is what happens if we antagonize the receptor, right? If we block the receptor. And then I've got in parentheses for a couple of them, if we agonize it, meaning that we, kind of light up that receptor, what happens? But most of these is what are the effects of blocking these receptors? So what happens when we block histamine? Well, that's an antihistamine, right? And you've got histamine receptors all over your body, and you've got some in your brain, and that's why some of the histamine blockers, like diphenhydramine, they get into the blood-brain barrier versus something like a Claritin or an Allegra, which doesn't. And so that's why you don't get the sedation effects from those histamine blockers. So sedation in the CNS, the central nervous system, is one of the big effects of blocking histamine 1 receptors. There's also an antipyretic, anti-allergy effect that's more outside the CNS. So, helping you with the symptoms of allergies, sneezing, itchy eyes, itchiness, those sorts of things. Also weight gain. So blocking this receptor, and that's where a lot of our psychiatric medications cause weight gain. There's actually several mechanisms, one of which is through blocking the histamine 1 receptor. And then hypotension's not one I really think about, but it's something that was listed when I looked up the receptor. The next one, muscarinic acetylcholine receptors. So you've got nicotinic acetylcholine receptors, and you've got muscarinic. And the muscarinics are the ones that we really worry about. And the TCAs actually are pretty bad when it comes to this receptor. And so I'm going to go into that a little more detail, but the symptoms we think about are dry mouth, blurry vision, constipation, urinary retention, tachycardia, memory impairments, sedation. Blocking this receptor is often how we combat the EPS, the extrapyramidal pyramidal syndrome, that's seen with the antipsychotics, especially the first generations. Particularly blocking it helps with dystonia, not as much with the other EPS symptoms, and it actually can make tardive dyskinesia worse. But we'll go into a lot more detail when we go through the antipsychotics there. Next receptor is the norepinephrine transporter. We talked about that a couple lectures ago. It's an effect that we have that gives us an antidepressant effect. So your SNRIs are going to work on this receptor. Also, a lot of ADHD medications work on this receptor as well. So there's an antidepressant effects there, but also we get an increase in blood pressure here, tremors, sweating. And so some of the undesirable effects of blocking that reuptake of norepinephrine into the terminally, having more of it out there, the blood pressure increase is a big one we think about with the SNRIs and NDRI. Next receptor, it's a serotonin transporter, the SERT. So this is where the SSRIs and the TCAs as well, and the SNRIs and many different medications work on this receptor, blocking the reuptake of serotonin. We talked about that a couple lectures ago as well. This is where we get some antidepressant efficacy, but also nausea, loose stools, sleep problems, um, problems with orgasm, erectile dysfunction. And when I get into the SSRIs in the next lecture, we'll go through where that's coming from in more detail. But, this is where we get a lot of the GI side effects, because we've got these serotonin transporters in our gut as well. The next transporter, the dopamine transporter, this is where your ADHD medications and bupropion interact at this receptor. And so when we block it, we get improved attention. Appetite is typically decreased. Mood can be improved. There can be some interactions with addiction, the liking behavior when we talk about dopamine. And so we'll get into that when we talk about the medications that interact at this receptor. And then the next series of receptors are all the serotonin receptors. And so if you'll remember before, when I talked about the serotonin transporter, when you block that, you're increasing the amount of serotonin in the cleft. And that serotonin interacts with all the serotonin receptors. And we're going to go through all the serotonin receptors. But there are medications that interact and they act as serotonin at specific receptors, sometimes agonizing the receptors, sometimes antagonizing the receptors. And when I cover the antipsychotics, I'm going to go into a lot of detail of what is all this agonist, inverse agonist, antagonist, like what is the details of what that is. Partial agonist would be another one. But for now, antagonist means we're blocking the receptor. Basically, the chemical that interacts with the receptor, serotonin in this case, is prevented from getting to the receptor because the med would be sitting on the receptor, making it to where the serotonin can't get to it. And if we're agonizing it, that's where the med is acting like serotonin, right? Because serotonin agonizes all the serotonin receptors. So if we block it, that means we're preventing serotonin from getting on there. If we agonize it, it means the drug is acting like serotonin. So you're getting an enhanced effect. So that's kind of how that works. So the first of the serotonin receptors that we're going to talk about is the 5-HT1A. Now, 5-HT, that's 5-hydroxytryptophan. That's the other name for serotonin. And then you've got all these number letter combinations. So this is 5-HT1A. We've got anxiety is one of the effects here. Buspirone is actually an agonist at this receptor. Memory, learning, depression. There's actually a new antidepressant we'll talk about later in our depression series. Gepirone may help with depression. It acts at the 5-HT1A receptor. Anti-analgesia, aggression. Those are not things I really think of that much with 1A, but they are listed as potential effects of blocking 1A. The next serotonin receptor, 1B. This is found in the cerebral arteries and causes them to dilate. And then I'll just mention 1D. So 1B and 1D, they both affect those cerebral artery dilations. And what does that? The triptans, right? So this is if you have migraine headaches, the triptans are actually agonists at these two receptors, and that's what can help relieve those migraine headaches, because we think the migraines are related to the dilation of the arteries causing pressure and pain. And what you'll note is I didn't mention 1C, and we'll mention that a little later. So we want 1B, 1D, 1E. Not real clear what 1E is involved in. 1F, it's another migraine related receptor, and there's actually a newer medication called lasmiditan. If we get into pain medicine stuff a little later, we'll talk about that. So lasmiditan is actually an agonist at 1F, and it's a migraine medication. All right, so now onto the 2 receptors, 5-HT2A. This is a big one. Okay. So depression is affected by this receptor, so mood. And so interestingly, what I've read is that the depression is actually helped by either agonizing or antagonizing this receptor. I'm not really clear on why that would be the case, but apparently interacting with 2A at all can help your depression. REM sleep's involved with this receptor, anxiety, EPS again. So a lot of the second generation antipsychotics act at this receptor, and that's how they're thought to kind of help with the EPS symptoms that the first generations cause through D2 blockade. Also, the negative symptoms of schizophrenia, it's thought that maybe the second generations are better at that, though that's kind of a controversial idea, but it's their interaction through the 2As where that's thought to happen. Sleep, so blocking 2A makes you sleepy. Trazodone, its main site of action is at 2A, so that's why trazodone makes you so sleepy. It's not a histamine blocker. It's the 2A blocker is what's causing that sedation. And then if you agonize the receptor, it's thought to improve sexual side effects. So mirtazapine, Remeron, actually is an agonist at the 2A receptor. And LSD, and all of the psychedelics, they act at this receptor. So agonizing the crap out of 2A is thought to be what gives a lot of the psychedelic effects. So most of our, I mean, I would say all of our medications that are approved legal use don't cause this psychedelic effect because they just don't enhance 2A to the point it's something like LSD or peyote or mushrooms or something like that does. 2B receptor, also related with cerebral artery dilation. And 2C, so this is the one that used to be called 1C, but I guess what they ended, it was called 1C, and then they found the twos and said, oh, that 1C actually looks more like a 2, so let's change it to 2C, and now there's no 1C anymore. So 2C is another big one. Helps with anxiety, mood, um, sleep, appetite. I mean, this is where the antipsychotics and mirtazapine increase appetite at blocking 2C, um, and erections, sexual behaviors. So mirtazapine, this is one reason why mirtazapine is thought to not cause the sexual side effects, because serotonin is an agonist at this receptor and it causes problems, and whereas mirtazapine blocks it. And so that's where mirtazapine is coming in, because remember that you're when you're blocking the reuptake pump, the serotonin reuptake pump, you're blasting more serotonin into the receptor, and so it's agonizing these receptors. But by blocking it like mirtazapine does, we actually can counteract that effect. And we'll go into more detail with that when we get to mirtazapine. And then the 5-HT3 receptor, we're still going. There's tons of them. This is where a lot of the nausea medications, so like Zofran, ondansetron, acts at the 3 receptor. And this is kind of where we think when we have more serotonin, it's what causes us to be nauseous. So by blocking the 5-HT3 receptor, we're counteracting that nausea. And so a lot of the GI effects, adverse effects from the serotonergic medications, this is where they're causing some of those GI effects, is through the enhanced activity of serotonin at the 5-HT3 receptor. And vortioxetine actually blocks this receptor, so might be better tolerated from a GI standpoint. 5-HT4, this is blocking it causes less GI motility. So agonizing it actually increases GI motility. And there's some medications. Cisapride is one that agonizes this receptor to help with GI motility. This receptor may also be involved in memory, learning, and depression as well. And then we've got 5. So there's a 5A and a 5B. 5A is thought to have things to do with memory consolidation. 5B is thought not to have any effect on humans, but it does on rodents. And then 5HT6, another one that we think has things to do with mood, anxiety, and cognition. And then lastly, finally, 5HT7, and also thought to have action on mood, anxiety, and cognition. And vortioxetine and lurasidone actually block this receptor. And so there's some thought that they may help to improve cognition. And that's where these cognition claims come in with vortioxetine and lurasidone. And we'll touch on that when we actually talk about those medications. Still going with the receptors in the brain, I want to talk about the adrenergic receptors. And so these are your alphas and your betas. There's alpha 1, and there's an A, B, and D subclass of 1, but as far as I can tell, A, B, and D, there's not a big difference in what those do. So the alpha 1 receptors, blocking them, this is one reason why antipsychotics and the TCAs can cause orthostatic hypotension, so lowering your blood pressure when you stand up, making you feel dizzy. Some sedation found here, dizziness, increased heart rate, priapism, so that's an erection that won't go away. This may be where trazodone, there's a risk of trazodone causing that, and it is a blocker at this receptor. There can be some GI upset, blurred vision, some sexual effects, nasal congestion. And the medications I think of that blocking alpha 1 are the zosins, so prazosin, terazosin, alphazosin, medications that are used for a long time ago high blood pressure, but now used for enlarged prostate mostly, and also nightmares. So we'll talk about that when we get into PTSD. And the zosins and trazodone and the tricyclics actually interact here. The next adrenergic receptor, A2, A, B, and C. So we think there might be some depression going on with the antidepressant quality to blocking it, arousal, libido, anxiety, tachycardia, dilated pupils, tremor, sweating. But I mostly think of the agonists like clonidine, which is a blood pressure medication, and tizanidine, which is a muscle relaxant. They agonize the alpha 2, which lowers blood pressure. So it's blocking alpha 1 lowers your blood pressure, but agonizing alpha 2 lowers your blood pressure. So that could be a little confusing, but it's kind of opposite there. And then we have 3 beta adrenergic receptors. And remember, also, I forgot to mention, so when we talked about the 5-HT receptors, those are the receptors that serotonin interacts with. The alpha and the beta are actually the ones that norepinephrine does. So when we're blocking the reuptake of norepinephrine with that norepinephrine transporter, medications like the SNRIs, we're actually increasing the activity. We're agonizing these alpha and beta receptors. And so that's where a lot of those side effects and positive effects are coming in. So the beta 1 receptors, I think of those mostly kind of in the heart, maybe a little bit in the kidneys. So you can get some decreased heart rate and lower blood pressure. The beta 1 and beta 2 medications, the ones that block those are your LOLs. So that's like propranolol and atenolol and metoprolol. And there's about 12 of them. So I won't list them all. And some of them block beta 1 a little more, some block beta 2 a little bit more. We can get into this in a later lecture as well. But I think there's some effect that might help with anxiety. Often these are taken for stage fright, things like that. We'll talk about that when we get into the anxiety lectures. And so beta 1 mostly in the heart and beta 2 mostly everywhere else. And beta 3 actually in the bladder. And so there's a couple of medications that block beta 3 that there are newer medications been out the last few years. So mirabegron and verebegron, um, they agonize the beta 3 receptor, which relaxes the bladder, or counteracts the relaxation of the bladder, and so they help with overactive bladder. So say that again. So blocking beta 3 would relax the bladder. So agonizing it actually causes the opposite effects of tightening it up so that it helps with the symptoms of overactive bladder. I think there's just the two beta 3 agonists that are out now. The next receptor we're going to talk about is GABA. And there's an A and a B. And so GABA is um, the main chemical in our brain that kind of slows things down. And glutamate, the one we're going to talk about next, is the main excitatory. So glutamate excites and GABA relaxes. So it slows things down. And so GABA is the actual chemical that interacts with GABA A and GABA B, but there are medications that specifically target one or the other or both. And so agonizing GABA A can cause sedation, make you feel sleepy. It can help with anxiety. It can be an anticonvulsant, so help with seizures, and then could also work as a muscle relaxant. And GABA B does very similar things. But GABA A is interacted with by benzodiazepines, alcohol, and the Z hypnotics like zolpidem, Ambien. And then B is interacted with baclofen, which is a muscle relaxant, GHB, which is a illegal substance that we'll talk about when we talk about illegal substances, and Phenibut, which is it's actually legal in Russia, but I'm not sure where else. I actually had a patient that was ordering it in the mail, so we'll talk about Phenibut when we talk about anxiety. So those are the GABA receptors, and then the glutamate. There's actually 4 different types. So you've got AMPA, NMDA, the uh, M-glutamate receptor, and CAR, which acts on natural killer cells, which are in our immune system. And so this is the excitatory chemical, the glutamate. And so those are the 4 types of glutamate receptor. And the main one of interest for us would be NMDA. And so that's interacted with by ketamine, dextromethorphan, PCP, and there's a lot of research now for antidepressants that are affecting NMDA. And so we'll cover that a little later as well. The next one I want to talk about is the sodium fast channels. This one is not one that's in the brain, but I mention it because this is where TCAs cause the serious problems, right? And so this is in the heart. So the sodium fast channels, blocking them, which is what TCAs can do, leads to a delayed repolarization that leads to arrhythmias, seizures, and delirium. So that's the bad effects there that we don't want with the TCAs. And then there's the dopamine receptors. So you've got the type 1 receptor, you've got the D1, 2, 3, and 4. D2 is the ones that we're mainly dealing with psychosis, schizophrenia, the extrapyramidal symptoms, prolactin elevation. So a lot of when we talk about psychosis and the antipsychotics, we'll talk about D2. And then D1, where it's thought to be involved in memory, learning, and addiction, and D3 and 4 are also, we think, related to psychosis and movement. But there's actually one antipsychotic that hits mostly D3. It's cariprazine. But most of the rest of them are dealing with D2. So that was a lot there, but I think it was good for us to go over all the receptors because all the medications we're going to be talking about from pretty much now on out, from the antidepressants, the anti-anxiety medications, the antipsychotics, the ADHD meds, sleep meds, these are all the receptors that are involved. And the TCAs actually have some of the most complicated interactions at these receptors. And that's why I wanted to bring it up now.